Good evening. Hi, everybody. I'm Adrienne Windsor. I'm a member of the board of the Newport Beach Public Library Foundation, and I'm just so pleased to welcome you all here tonight for Medicine in Our Backyard. It's our second on-site meeting after 2 years of Zoom, so I hope you were all Zooming with us too during those days. I always like to begin by thanking our sponsors. We have, first of all, UCI Health, who's been with us ever since we started this. We started it around them. And then Mike and Polly Smith, who've been our benefactors every year. They have sponsored Medicine in Our Backyard so that we can offer these lectures to you free, and we can bring the UCI medical community to share with us in what they know. There are two people also I want to thank who don't often get thanked. One of them is Kunga Wangmo Upshaw. Kunga greeted you when you came in. She is our program director. And Jane Merritt, who's back there, she's with UCI Health. These two women coordinate this whole program, and they put it all together, and they're always here, and they've been so devoted to us, and so I just wanted to acknowledge them. Now, I've told you this many times before, but we are a membership organization. How many of you are members? Oh, that's great. And our foundation does things for the library that the city doesn't do. The chairs you're sitting on, the foundation provided. We provided computers upstairs, the computer tables, the media lab, and now the foundation is involved in a fundraising drive for the new Whitty Lecture Hall. So we will soon, in 2 or 3 years, we don't know exactly when, but we will have that new facility, which will be a great boon to the whole community. So we're just happy to have you here tonight. We hope you will become members. We have upcoming Whitty lectures that will be starting in January. Everything is posted on our website. And on November 17th, the LA sports columnist Bill Splatsky is coming to speak for Library Live. So we'd love to have you here for that too. Now, just a few reminders. If you haven't silenced your cell phones, please do that now. Thank you. I see some of you are. And we will conclude the program with Q&A, so please hold your questions until the end. And then both of our speakers will be up here to answer your questions, and I will come out into the audience and bring the microphone for you. So I'm just thrilled to introduce our speakers tonight. We have two such powerful women. And when you say a woman is a chief and she's head of something, it's really an extraordinary achievement, and both of these women have achieved that status. So our first speaker will be Dr. Irene Tsai, and she is the Director of Breast Imaging at the UCI Medical Center in Orange and UCI Health in Yorba Linda. So you commute back and forth to both of those facilities, plus she's raising children. Isn't that extraordinary? She's also the interim chief of breast imaging in the Department of Radiology Sciences and director of the Breast Imaging Fellowship Program. Our second speaker is Dr. Kari Kansal. She's a board-certified UCI Health surgical oncologist. She specializes in diagnosing and treating breast cancer and benign breast diseases. She earned her medical degree at the University of Minnesota Medical School. I forgot to say Dr. Tsai has her medical degree from the David Gessen School of Medicine at UCLA. So they have amazing credentials. Dr. Kansal completed her internship and residency at UC San Diego, and then a second fellowship at Mass General Hospital in Boston, and the Dana-Farber Cancer Institute and Brigham and Women's Hospital in Boston. Brigham and Women's Hospital in Boston. So tonight they are going to be telling us how to reduce our breast cancer risks. Dr. Tsai will speak first, followed by Dr. Kansal, and then we will have our Q&A. So thank you for being with us, and please join me in welcoming Dr. Tsai.
Good evening, everybody. Thank you so much for joining us this evening. And thank you so much to the Newport Library Foundation for hosting us and for sponsoring this wonderful lecture series. Dr. Kansal and I will be speaking tonight about how to reduce your breast cancer risks. Oh, thank you. Great, thank you. So again, Dr. Kansal and I will be speaking tonight about how to reduce your breast cancer risks. And in particular, I will be highlighting how you can reduce your risk with the aid of breast imaging. So I wanted to first briefly speak on the effects of the pandemic on breast imaging as a whole, and specifically the effects that we have seen on screening mammography, not just here at UCI, but also across the nation. During the height of the pandemic, due to various government and hospital mandates to hold non-emergent and elective cases, radiology exams as a whole decreased by 40 to 90%. And this greatly impacted breast imaging in particular. It has been reported that 97% of United States breast imaging facilities were either closed or operated at a reduced capacity from March to September of 2020. Though it is too early to calculate the true impact of what this deficit means, it has been postulated that even a 3-month delay in breast imaging can increase breast cancers diagnosed at advanced and later stages, lasting all the way until 2029. Then we started to see the effects of the COVID-19 vaccine on screening mammography. And specifically, there were initial recommendations suggesting that mammograms should be delayed for 4 to 6 weeks following the COVID vaccine. And the reason for that is this. So COVID vaccine-related lymphadenopathy that was identified on screening mammography, as you can see here. So with the COVID vaccine, we have seen pretty prominent, exuberant, swollen lymph nodes in the armpit or axillary region, as you can see on this mammogram here. Now, it is a normal immune response for lymph nodes in the armpit to become swollen following a vaccine. And we have seen this in the past in the setting of mammography in previous vaccines such as the flu vaccine and the shingles vaccine. But the COVID vaccine in particular, again, we have seen very, very prominent exuberant lymphadenopathy in the armpits. And this, now that we know this is a known side effect, and this can in fact persist for several months. That is why now the current recommendation by the Society of Breast Imaging is that mammogram is no longer delayed surrounding the vaccine. But your mammography technologists will be asking you when you have your mammograms performed, when your last vaccine was administered, and in which arm, because we can use this information to place things into clinical context if we see this vaccine-related lymphadenopathy. And again, now any further delays in screening mammography should be avoided at all costs. And that is because time and time again, screening mammography has been shown to save lives, as mammography catches breast cancer at its very earliest stages, where prognosis is the best. Now, 1 in 8 women in the United States is diagnosed with breast cancer in her lifetime. And mammography is a screening test that helps, again, detect breast cancer at the very earliest stages, even before any clinical signs or symptoms can be apparent. And more than 39 million mammograms are performed annually in the US. Now, it has been shown that commencing mammograms starting at age 40 and then continuing annually until you are in good health saves the most lives across all age groups. And that is why the official recommendation by our American College of Radiology and the Society of Breast Imaging is, again, commencing at age 40 and continuing annually until you're in good health. Now with mammography, there are additional tools that we can utilize to help reduce breast cancer risks. With conventional traditional mammography, 4 static images of the breast were taken in 2D. But with 3D mammography, which was FDA approved in 2011, otherwise known as 3D tomosynthesis, multiple very low dose projections of the breast are taken, which allows us to see through a cross-section of the breast. And here is a short video that depicts how 3D mammography is performed. Again, 15 low-dose exposures of each breast are taken over about a 3-second time span. And then these images are sent over to a radiologist and reconstructed to 1 millimeter thick, very high resolution slices. And you can see in this video, these thin slices help us see through the breast tissue. In this example here on a regular 2D mammogram, no findings were apparent, but the additional slices can show irregularities or suspicious findings better. And this ended up being a biopsy-free cancer. Now, compared to 2D mammography alone, 3D mammography has been shown to detect 41% more invasive breast cancers. It has also been shown to reduce callbacks by 40%. Now, a callback is when a patient has a screening mammogram performed, and then they are asked to return for additional imaging because there are inconclusive findings on the screening mammogram. Now, 3D mammography has been shown to reduce these callbacks or returning for the additional imaging by 40%. And it has also been shown to benefit women of all ages and all breast densities. Now, speaking of breast density, what does this mean, and what does it mean for your mammogram? So all breasts are made up of fibroglandular breast tissue, which appears white on mammogram, and also fatty tissue, which appears dark on mammogram. The more fibroglandular breast tissue that you have in relation to the fatty tissue, the denser that your breasts are, and then the wider that this tissue appears on mammogram. As you can see in this example, there's a wide spectrum of different breast densities that you can have, starting with, in this first image, mostly fatty tissue, and extending all the way to very dense, extremely dense breast tissue that we see in this example. Now, in particular, breast radiologists prefer 3D mammography in patients with dense breast tissue, because as you can imagine, the 3D slices can help us see through this dense breast tissue better. Now, here is an example of where 3D mammography could have helped reduce a callback. So this is a case in which a finding was suspected on a patient's initial 2D mammogram, this high-density area here. And then the patient returned for additional 3D imaging, which showed that this density is just normal overlapping fibroglandular tissue. Therefore, these additional images and the patient having to return could have been avoided if the patient had 3D mammography to begin with. Now, here is an example where 3D mammogram helped us to improve cancer detection. So on this initial 2D image, really no suspicious findings were seen. But on the 3D tomosynthesis slices, you can see that there is a high density abnormality in the superior breast. And here is a close-up of this finding, which shows this irregular, hyperdense, what we say spiculated mass. And subsequently on ultrasound, you can see this very irregular, suspicious mass. And this ended up being a breast cancer. Now, I'm proud to say that 3D mammography is the standard of care at UC Irvine, and we offer 3D mammography at all of our UCI breast imaging locations. Now, on to another imaging modality that can help mitigate your breast cancer risks and can be particularly helpful in patients who have denser breast tissue, and that is screening breast ultrasound. Now, mammography does have some limitations in the setting of patients who have dense breast tissue. In particular, it can mask masses that are similar density to tissue. So as you can see in this first example, this patient has predominantly fatty tissue, and this irregular high-density mass is very well seen in this context where the patient has mostly fatty tissue. But you can imagine in a patient with denser breast tissue, because the density is the same as this irregular mass, it can make things harder to appreciate. And that is why screening breast ultrasound in conjunction with mammography can help add additional information to the picture. Now here is an example of a patient who had a 3D mammography and was found to have a very subtle finding seen within the superior breast. And then subsequent same-day screening breast ultrasound shows this much more obvious, irregular, what we say hypoechoic mass. Now here is another example where mammography showed just a very, very subtle finding in this central middle of the breast region. And then same-day screening ultrasounds showed this very tiny but suspicious irregular mass, and this was biopsy proven to be a breast cancer. And finally, another imaging modality that can help mitigate your risks for breast cancer is MRI. Now, breast MRI is the most sensitive imaging modality that we use to evaluate breast tissue, and it can be added to both mammogram and ultrasound for annual screening in patients who are considered high risk. Now, what does that mean? So high risk means that you have a greater than 20% risk for developing breast cancer. And this is based on risk factors such as your family history, whether you have the known BRCA/BRCA cancer gene, whether you are a first-degree relative of somebody with the BRCA cancer gene, or if you've had previous radiation to the chest wall between ages 10 and 30 years old, for example, in a setting of a prior lymphoma diagnosis. Now, these are just some of the types of risk factors that can put you at a greater risk for developing breast cancer. Therefore, screening breast MRI can be particularly helpful in conjunction with screening mammogram and screening ultrasound for your routine yearly screening. So here is a case in which a high-risk patient came in for a screening mammogram and was found to have this asymmetric density within the left breast compared to the right breast. The patient then went on to have breast MRI, and you can see this very extensive, suspicious enhancement throughout that left breast that corresponded to the area that we saw on mammogram, but much more extensive. And this was biopsy proven to represent a form of breast cancer called ductal carcinoma in situ. Here is another example in a high-risk patient who came for mammogram, in which a very subtle finding was seen within the superior breast here. And on subsequent MRI, that finding corresponded to this, what we say, enhancing mass on MRI. But she was also found to have all this extensive enhancement extending beyond the mass that really was not apparent on the initial mammogram. Now, we can also utilize breast MRI as a diagnostic tool in patients with known breast cancer to determine their extent of disease. In this example, this patient had a known breast cancer, as you can see here, and it wasn't until she went on to have a breast MRI that it was discovered that she had additional suspicious enhancement seen throughout the bones or the sternum here. And this ended up being metastatic disease from her known breast cancer to the bones. So as you can see, really the power of breast MRI here and how it very much can change the course of a patient's treatment. So in conclusion, there are ways to reduce or mitigate your breast cancer risks utilizing breast imaging, and that is annual screening mammography beginning at age 40, which has been shown time and time again to save the most lives. Utilizing powerful tools such as 3D mammography and breast ultrasound, particularly in patients who have dense breast tissue. And finally, considering the addition of supplementary screening breast MRI in patients who are considered high risk. And in this patient population, mammography, ultrasound, and breast MRI, all in conjunction as screening tools, can give us the most information and the most comprehensive picture of your breast health. Thank you.
Just turning it a little. Well, good evening. Thank you so much, Dr. Tsai. She says it's so easy to see these things, but as you can tell, being a breast imager is a very, very challenging job, and thank goodness we have people as good as Dr. Tsai to find these cancers. I wanted to talk a little bit more about breast cancer risk in general, as well as risk mitigation, and I think no talk from a surgeon would be complete without a little bit of discussion about different surgeries we can do. So what are the facts? What you've already heard tonight is 1 out of 8 women will be diagnosed with breast cancer in their lifetime. Unfortunately, this is becoming such a ubiquitous disease among women primarily. 1 in 8 really equates to about 12 to 15% lifetime risk of getting breast cancer. Now, what most people don't know is 85% of those patients have no family history of breast cancer. So many of my patients who come in with a cancer diagnosis say, it can't be, there's no one in my family who's had this. But the vast majority of breast cancer diagnoses are what we call sporadic. There's no family history. The good news is about 93 to 95% of women who are now diagnosed at an early stage, the reason why we recommend screening mammograms, are surviving past 5 years. And this has really changed within the last decade for many different reasons. But unfortunately, you can see the numbers still here. Almost 300,000 women in the US are diagnosed this year. Now, when we look at the people who are getting breast cancer, as you can imagine, the vast majority are women, but 1% of all diagnoses are in male. So we do have to pay attention to this as well. And lastly, breast cancer is still the leading cause of cancer death behind lung cancer. So this is really important that we continue to make strides in helping survival. So who's at increased risk? As you heard me just say, women. Women over the age of 50, we start to really see an increase in the incidence of breast cancer. Those who have a first-degree relative, especially who was diagnosed with breast cancer, or anyone with ovarian cancer in their family. You've heard about the BRCA1 and 2 genetic mutations that can put people as high of a risk of 80% of getting breast cancer in their lifetime. But we know there's up to 140 mutations that we're finding that place patients at a higher risk of getting breast cancer in their lifetime. I think what we know about genetics is that we're just at the tip of the iceberg in what we know thus far. Those with an Ashkenazi Jewish heritage have a higher risk. Estrogen exposure due to menstrual cycles and exogenous hormone exposure, like taking combination estrogen and progesterone hormone replacement therapy, increases the risk of breast cancer. If a patient has had biopsy and they find that they have atypical cells, this can increase the risk of breast cancer up to 30% lifetime risk. Dense breast tissue, as you just heard from Dr. Tsai, not only does it make it harder to find breast cancers, these patients also have a higher risk of getting breast cancer. And lastly, you already heard about the radiation therapy. So what can we do to modify the risk factors of getting breast cancer? Because many of these things are just how we're born or our DNA, but there are some things we know and that we can change to decrease our risk. Not being physically active is a very important thing that we can change that makes a large difference. In addition, patients who are overweight or obese have a higher risk of breast cancer. You may wonder why about this. The reason for this is any estrogen in the body stimulates our breast tissue and therefore causes the cells to turn over more quickly. So, as you can imagine, as we age, that estrogen from our ovaries may diminish, but we create estrogen in other areas of our body, and one of the main areas is in fatty tissue. Many studies have shown that women who are postmenopausal, who gain weight in their postmenopausal years, are then at a higher risk for breast cancer. In addition, women who carry their weight around their central aspect of their body also are at a higher risk of breast cancer. Exogenous hormones, like hormone replacement therapy, increases that risk. And it increases the risk by 1% to 2% per year that patients are taking hormone replacement therapy. Now, there's a lot of discussion about this. People will say, but I'm taking bioidentical hormones, so it's not going to increase my risk. But all hormone replacement now is bioidentical. They're made to be just like our hormones that we have in our body. The risk is increased when we have estrogen plus progesterone. And there's very little risk, actually, for breast cancer when taking estrogen alone. So many postmenopausal women have challenges with recurrent urinary tract infections, vaginal atrophy or dryness, and using some local estrogen therapy really does not change the breast cancer risk at all. Interestingly, having a first pregnancy after the age of 30 increases your risk of breast cancer. So nowadays, most women are having their first children in their 30s, and so this automatically increases their risk of breast cancer. It's not a big increase of risk, but when you start to add up all of these different risk factors, you see these risks can really start to climb. The reason that this can cause an increased risk of breast cancer is that having a pregnancy prior to the age of 30 kind of arrests this parenchymal development in the breast tissue. We're unsure why it doesn't happen after the age of 30 as well, so something that there's continued research in. Interestingly, in the past about 5 years, we've found that alcohol intake can really increase the risk of breast cancer. They say more than 4 alcoholic beverages a week, also known as moderate drinking, can increase the risk. And lastly, smoking. Smoking increases the risk of almost all cancers. So I touched on earlier about abnormal cells on biopsy. So when our breast radiologists are doing mammograms, sometimes they see things called microcalcifications. There's calcium deposited in the breast, and it can be there for many, many different reasons. But when they have a certain look to them, the radiologists are concerned. It could be an early cancer or abnormal cells, and so they'll do what we call a core needle biopsy. This is when they numb up the skin and place a small needle into the breast and take some samples of that breast tissue. Sometimes we find things called atypical ductal hyperplasia, lobular hyperplasia, and lobular carcinoma in situ. All of these atypical cells can increase a woman's risk of breast cancer to up to 30%. And this risk factor can be in either breast. So although we biopsy one side, it portends a higher risk in both breasts for these patients. But the good news about this is we have some wonderful medications called what we call chemoprevention that can decrease the risk of breast cancer in patients like this by 50%. And the way that these pills work is by decreasing, once again, the estrogen exposure to the breast tissue, because that's what can increase our risk of breast cancer. So chemoprevention are medications that decrease the risk of breast cancer. You can see there's 2 main groups of medications. I'm sure many of you have heard about tamoxifen or raloxifene. These are 2 medications that directly inhibit the binding of estrogen to the breast cancer cell. Now, estrogen, when it does bind to the breast cancer cell, it can lead to proliferation, which is cell division, tumor growth, angiogenesis, which is recruitment of blood flow to that area of the cell division, and then metastasis. So tamoxifen, when you take it as a pill, it binds to this estrogen receptor so that the endogenous or your normal estrogen does not have a place to bind, and therefore it blocks this kind of regulation or blocks this proliferation down the line. We typically use tamoxifen in younger premenopausal women. There's also a drug called raloxifene, which I'm sure many of you have heard about, and we use that to treat osteoporosis. But that drug works exactly the same way. And in clinical studies, it's been shown to reduce breast cancer risk by about 50%, if not even a little bit more, the same as tamoxifen. So we have some fantastic medications that we can use to decrease breast cancer risk. To be complete, there's another classification of other medications we use called aromatase inhibitors. You can see here in the body, we have other hormones like testosterone and some hormones that are precursors to estrogen. In our peripheral tissue, like our fat, liver, muscle, we have an enzyme called aromatase, and this is what converts those precursors into estrogen. That estrogen is used the same way when it gets to the cancer cell, and it then leads down to the growth of the cancer. So we have a group of medications called aromatase inhibitors, which block this enzyme and therefore decrease the level of estrogen within the cancer cells. So between these 2 groups of medications, we have a lot of fantastic options for decreasing risk. So most patients who are at a risk of greater than 20% lifetime risk of getting breast cancer are considered high risk. So at UCI, we've started a high-risk clinic so we can take care of patients as carefully as we can who are at high risk. We have our patients come in for high-risk screening protocols, which you've already heard. That's with screening mammogram once a year, alternating with a breast MRI. We have a visit with a breast surgical oncologist like myself to do a clinical breast exam and try to elucidate any concerning symptoms that you may not even think of. You'll also meet with a medical oncologist. They talk about those pills that we talked about just a moment ago, the chemoprevention pills. If your family history is one that would require a genetic counselor, we set that up as well. And lastly, we educate on the newest research and clinical trials. We have a current clinical trial at UC Irvine that's helping to educate patients about these medications, the chemoprevention, to reduce risk. In addition, we all feel that decreasing a breast cancer risk is really a holistic adventure to go down. So we also have partnered with the Susan Samueli Health Institute to have more of a holistic approach to our patients and their breast cancer risks. So this is a comprehensive approach, and we look at, as you can see everything here, not only the genetics we've been made up of and the other lifestyle issues that can increase our risk, but they're also looking at environmental exposures, immune system function, genetic predisposition, epigenetics, which is environmental factors that can actually change our genetic makeup, stress and the stress response, and how this is affecting our risk of breast cancer. So by working hand in hand, we're able to really make strides in terms of decreasing that risk. Just to turn things around a little bit, surgical advances. Historically, when we would find something on a mammogram or an MRI that we couldn't feel, we needed a way to localize that area to remove in the operating room. So we used to place a wire into the breast on the day of surgery. You can imagine as a patient, this is extremely stressful and uncomfortable because you can be in compression for a long time. You haven't eaten because you're about to have surgery, so many patients could even pass out at that time. It was awful. But the good news is now we have what we call wireless localizations. There's something called a Savvy Scout. This is what we use at UC Irvine, but there's multiple different technologies we can use to localize things in the breast when we go to the operating room to remove that area of concern. The Savvy Scout works using a radio frequency technology. So when you come to the operating room, I have a probe that I listen to the breast, and it beeps at me. It literally goes beep, 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 and tells me exactly where to go, so we can be very precise. Patients love this because our breast radiologists put these in far before surgery. They can do it the week before, a month before, and so we decouple that time and stress from the time of surgery. This is a piece of tissue that's been removed. You can see a small clip right here. Every time our radiologists do a biopsy in the breast, they leave a small clip behind so we know where the biopsy was done. This clip is tiny. It's almost like an eyelash that's been plucked and bended upon itself. So when I get into the operating room, I cannot see or feel this clip, nor do I want to, because it's typically embedded in the area from which I want to remove it. And that's why we need to localize it. Oops, sorry about that. With the Savvy Scout. This is what the Savvy Scout looks like. So the radiologist placed this right next to the clip. This was a small breast cancer. This is the area of the cancer. And this is an X-ray of the specimen in the operating room that we do right at that time to make sure we have the area of concern removed. This is a patient of mine, and this was used with her permission. You can see on this side she had a Savvy Scout placed. This picture is a few weeks after surgery, but over time this healed so you couldn't even see the scar, and she was very pleased that she did not have a breast cancer remembrance every time she looked in the mirror. Once again, that was the specimen radiograph. Now, there are patients who need to have a mastectomy, even though we would love to do breast cancer or breast conservation surgery on all patients. And there's multiple types of mastectomies. But the difference between them, there's three. One is called a simple mastectomy. One is a skin-sparing mastectomy, and one is a nipple-sparing mastectomy. From a cancer standpoint, they're all the same, and the only difference is how much skin is removed. All the breast tissue is removed, and no muscle is removed. This simple mastectomy is where the breast is removed, and it's just flat on that side. There's a scar that extends the width of the breast. Patients do not have a reconstruction at that time if they choose a simple mastectomy, and many will wear a mastectomy bra with a breast prosthesis in place when they go out or when they want to. But in order to do an immediate reconstruction with our reconstructive surgeons, we need to save the skin envelope so that the reconstructive surgeons have somewhere to place the implant or use the patient's own tissue to build new breasts. So this is another patient of ours. This is her natural breast. This is her reconstructed breast the day after surgery. You can see here her IV was just taken out before she was about to go home from her operation. The incision is under here. It's called the inframammary fold. From that incision, which is typically about 6 centimeters in length, we're able to remove all of the breast tissue and even access the lymph nodes. So we call this scarless surgery, although that is a bit of a misnomer because there is a scar, but when you look in the mirror, it's hidden. Also called hidden scar surgery, which I prefer. But as you can see, we save all of the skin, including the nipple and the areolar complex. Patients love this operation because when they go home, they look down, and when they look in the mirror, it really feels like themselves. But after any mastectomy, the chest wall becomes numb. And so patients lose feeling across their chest wall, typically the width of their hand, where the nipple and the areolar complex lives. Sometimes that sensation comes back with time, but most of the time it's permanent. They don't get that sensation back. So even when we save the nipple, it's only for aesthetic reasons. There's no arousal, there's no sensation with that nipple. But still, most patients really like to have this aesthetic. On the other hand, this is an example of a skin-sparing mastectomy. You can see the nipple and the areola is removed, but all the rest of her skin is left behind. This is also a different type of reconstruction. This is called an autologous reconstruction, where the plastic surgeon uses the patient's own tissue to build new breasts. She actually had hers taken from her belly. There's a scar that goes from hip to hip. It's a big scar, but it's like an abdominoplasty or a tummy tuck. So they take the tissue away from the abdomen. Then when I'm done, they come and they put that tissue into kind of the skin pockets, which are left behind after mastectomy, and they hook the blood vessels up from that tissue to blood vessels that are running behind the sternum or the bone on the chest. All this tissue needs to have blood flow. If we just take it out somewhere and kind of plop it in somewhere else, it's just going to die because it needs blood flow. So that's what they hook it up to behind the sternum. You can imagine this is much bigger surgery. It takes longer, but what's nice about it is aesthetically, it feels and looks like a natural breast. With time, it's going to age like a natural breast. If someone gains weight, their breasts will get larger, just like they do otherwise. If they lose weight, they may lose a little weight there as well. Patients always ask, though, but now what is my breast cancer risk now that I have these new breasts here? But the risk is still as low as it can be, 1% to 3% after mastectomy, because that fatty tissue does not have breast cells in it. It's from the abdomen or the back or the buttock or wherever they take the tissue from to create. Eventually, 50% of women go on to have nipples created or tattooed. The last really exciting thing I want to touch on is something called lymphatic surgery. So I'm sure many of you heard about the risk of lymphedema after we take out lymph nodes from under the arm, where cancer can be or is. Patients can have problems with lymphatic drainage of their extremities. The lymph system is a system in our body that's constantly flowing with fluid that brings immune cells to different areas to help us heal cuts, heal infections, and just sort of survey the body to find is there cancer somewhere. The way I like to think about it is the lymphatics are almost like train tracks where the trains can go along, and the lymph nodes are like the train station. In order for those trains to keep going through, they've got to stop at the lymph node, drop off their information, and then they keep going to the next stop. But when we do lymphadenectomy or we remove lymph nodes, we're taking those train stations away. So although the fluid, the trains, keeps coming into that extremity or the arm, it just starts to back up because it can't get out. So now what we've started doing in the operating room is we take a lymphatic vessel. So after I'm done with removing the lymph nodes in the area, this is under the arm. This is what the axilla looks like in the operating room. And we've removed all the lymph nodes in this area. This patient had cancer in her lymph nodes. So this is what it looks like. The lymphatic vessel is right here. That's where the lymph flows. And then there's veins throughout our body. So we dissect out a lymphatic vessel, and we hook that vessel up to the vein. So here you can see a fluorescent dye that's been injected that's flowing through the lymphatic system, and we can see it going into the vein. So the idea is we're bypassing those train stations, the lymph nodes that have been removed, and the fluid has a way to exit. This has been a game changer for patients who have lymphedema. When we do this prophylactically or at the time of the cancer operation, historically, if we removed about 15 to 20 lymph nodes, the risk of lymphedema could be as high as 40 to 60%. It was so common. Then we add radiation to that, and that also increases the risk even further. By doing this, in preliminary data that's come out over the past 5 years, we're seeing that risk of lymphedema after the same operation and radiation may be as low as 5 to 10%. This adds about an hour to the surgical procedure. In my book, well worth that hour. But what's the big deal about lymphedema? So this is an example. There's 3 different stages of lymphedema. You can see this is stage 1, stage 2, stage 3. So what happens over time is we first may notice just a little bit of fullness. Maybe our rings are a little bit tighter. It can be uncomfortable. Our joints can become very uncomfortable. But as it progresses, you can see it's not only uncomfortable, very painful, but psychologically it's challenging, and it's hard for patients to live with this. So when we have a patient who comes in who already has lymphedema, we've lost the opportunity to do the surgery that I just described, because that surgery, that bypass, can only be done at the time of us taking those lymph nodes out. So now we've started to do what we call a vascularized lymph node transfer. And this picture I actually found from the internet. It's from the Johns Hopkins website, but I couldn't find a better one, so I really like it. So what you can see in this picture, it shows in the axilla, this is where we do the lymph node dissection, and the yellow dots are the lymph nodes, the blue are the vein. They're trying to show in this picture the swelling on either side of the normal arm is the lymphedema, and the same in the legs. So patients who maybe have a lymph node dissection for a sarcoma, a melanoma of their lower extremities can get the same thing in their legs. So now we can go in, take lymph nodes. You wouldn't imagine, there's lymph nodes everywhere. They're just all over the place. So we want to take lymph nodes from somewhere where we won't be creating lymphedema somewhere else, and then we literally transplant them to the limb, which needs the drainage of the lymphedema. So this is really exciting. It's only done at a few places in the country, UCI being one of them right now. This surgery is a lot more. This is more than, this is a big time surgery, but we see great results and resolution of lymphedema in many situations. In that last example I showed you, when it gets to this point, unfortunately, much of this is not reversible, but we can also do what we call debulking surgeries, where we can remove a lot of the damaged tissue. And when we do that in conjunction with the transplant, many patients still go on to live much more comfortably without the lymphedema that they're suffering from. One last note about lymphedema is not only is it uncomfortable and it may be distressing for patients emotionally, but the real risk becomes infection for these patients. You can imagine our lymphatic system is compromised when we have lymphedema, and that's the system that is always in surveillance, trying to find infection and bring immune cells there to treat that infection. That's why our lymph nodes get swollen when we get a vaccine, because those lymph nodes get into action and create antibodies to treat whatever is going on in the body. If somebody is to get a cut, or let's say a cat bite, or something happens, we always talk about people in their gardening and they get a rose and thorn scratches their arm. It can become life-threatening. They may need to be hospitalized for IV antibiotics because their natural immune response is clearly not what it must be. So it's very exciting that we have this new technology to help patients who are in this situation. And I think that's my last slide. This is a schematic of our new hospital that we're building. The outpatient cancer center here is going to be open at the end of next year or beginning of 2024. So we're really excited about that as well. This is on the UC Irvine campus, actually off of Jamboree. So we can't wait because we'll have everybody together, radiation doctors, the surgeons, medical oncologists, our breast imagers, everyone's right there together, but also side by side with the Susan Samueli Institute, as well as our basic science researchers. And so what's fantastic is it's really a bench to bedside setup with the medical school there and the nursing school. So it's really going to be a fantastic situation. Thank you so much for your attention tonight. We'll take any questions.
Thank you so much. So Dr. Tsai, if you'd like to come up here too. I will be going out into the audience as you have questions to ask. I'd like to thank both of our speakers. It's been really quite wonderful to have their presentation. And you have a question?
Just a specific one about a name that you mentioned that I don't recognize, about a drug that's similar to tamoxifen, but that it's for osteoporosis.
Yeah, there's a drug called raloxifene.
Could you spell that?
Sure. Well, let's see. RALOXIFENE. There's an E at the end.
And are there any side effects with this drug as compared to tamoxifen?
So the side effects are less. A big reason why many patients end up not taking the chemoprevention medications is because of side effects. The common side effects of all of these medications when we block estrogen is similar to going through menopause, because that's what happens when we go through menopause. Our ovaries stop producing estrogen, and then we get hot flashes, vaginal atrophy, dryness, maybe some moodiness, hair loss, weight gain, all the things that nobody wants. Some of the drugs cause joint achiness and osteopenia, or bone weakness, thank you. And then other drugs, though, actually can build bones, like tamoxifen. It makes the bones stronger, but tamoxifen has side effect risk of blood clots as well, and endometrial cancer, as well as cataracts. Now, the risk of blood clot and endometrial cancer are way less than 1%. And all of the reported cases of endometrial cancer in women who are taking tamoxifen were found at stage 1, and just removal of the uterus was all the treatment that was needed. But still, the idea of it is quite scary. Taking a drug to prevent one cancer to get another one is not what anybody wants. So the side effects are real, and they are there. Raloxifene has less side effects than tamoxifen. It shows less side effect of uterine cancer, blood clots, or cataracts. It seems also to have less of the vasomotor effects, such as the hot flashes and so on and so forth. So it is much more tolerated.
So what about postmenopausal women with the raloxifene?
Yeah.
Opposed to anastrozole.
Yeah, so raloxifene can be used also. So it's interesting. There was a study that was done that looked at comparing tamoxifen with raloxifene to see which gave a better overall risk reduction for breast cancer. And they found they're pretty much equivalent. And most of the women taking raloxifene were postmenopausal who already had osteopenia or osteoporosis. So the study, called the MORE study, was looking at raloxifene and how effective it was against vertebral compression fractures But the secondary endpoint then was breast cancer reduction. And so all these medications can be used in pre- or postmenopausal patients.
But the relaxin will help osteopenia, like bone.
It does,
yeah,
it
whatever.
does.
Wait, you know what I'm trying to.
Absolutely.
I know,
It
I'm sorry. Can everybody hear my questions? I'm sorry. Yeah.
It helps build
Yeah.
the bones.
Okay.
Absolutely.
Yeah. Because that's always a concern for postmenopausal women. or
100%.
Many of us.
Yes, yes, yes.
Thank you.
What about Forteo?
Oh, wait, just a second, and I'll come to you next.
Is there an age when it's no longer necessary to have mammograms?
Well, there's no specific age in which we recommend stopping mammography. We just say to continue annually starting at age 40 for as long as you are in good health. So there really is no set age cutoff. Previously, there have been recommendations as early as 74, 75, which seems, ridiculous to me. I mean, 74 is the new 21. So now the recommendation
Glad to hear that.
the recommendation is to continue for as long as you're in good health annually.
And if you're not in good health, then it's not. If you're not in good health, it's not a good idea unless you talk to your doctor about it.
Yes,
or,
yes,
you know.
then that is a discussion that you can have with your primary doctor or whoever manages your breast health to determine, hey, the risks and benefits of mammography, does it decrease over time in patients who are not as much in good health? But definitely, if you are in good health, continue every year.
I was just wondering about a drug called Forteo.
Well, I was just cheating and looking it up because I don't know the answer. I'm not sure. Do you come on, Dr. Tsai, do you know? It is, but I don't know. It's breast cancer reduction. Yeah. I don't think it has a breast cancer risk reduction, but I don't know for sure. So, yes, sorry.
No, they're still finishing up. What are your thoughts on the new blood test by GRAIL? It's called Galleri, and it tests, it shows the shedding of cancer cells, and it shows very early diagnosis of about 50 different cancers, including breast cancer. What are your thoughts on that?
So the idea of the liquid biopsy is very exciting. That's kind of what we call it, where we can take a vial of blood like you would for any lab and look for tumor cells within it. There have been many, many challenges with this. We actually can do it quite easily, and we've been doing it for a long time in the laboratory, and it's starting to roll out now to patients. But the problem is many, many things with it. We're finding that some patients are told that they have cancer cells in their blood, but then we can't find that cancer, so it causes a lot of undue stress and anxiety. In addition, when we have cancers in our body, they're always shedding cells. That's the idea of the liquid biopsy. They're always shedding, and so these cancer cells can be found throughout. So not only is it just cancer cells, it can even be just tumor DNA or pieces of cancer. But many times our body's already fighting off a cancer that would never become clinically apparent either. And so we just haven't found the right way to use these biopsies, these blood tests quite yet, where it's going to be helpful from a screening standpoint. One area where patients or medical oncologists are starting to use it more is more for screening or for recurrence. So we've known somebody has already had a cancer, and now we're following their blood work to see if we can find any sign of tumor DNA that's kind of resurfacing and floating around. It's a little more helpful because it's more specific, but still we haven't found a great use for it because once again, many times we can't detect any cancer, then we all kind of just sit there and wonder what to do next.
I mean, so it will tell you that the cell they're seeing is a breast cancer.
So, and even with that, because there's lots of receptors and what we call biomarkers on all different cancers, so we can tell really where it originated from. But say you get that test and they say, yes, we found a breast cancer cell here. First step is you'd probably come to Dr. Tsai or someone like her and get breast imaging, mammogram, breast MRI even, ultrasound, all of the different things, and then we can't find it. Or maybe we do, but many times we can't find it. And so then we're stuck in a bit of a conundrum because we don't know what to do with that information. You know, it's not enough to say, well, now we'd have to remove both breasts to try to find the cancer. But so I think it's exciting technology that's going to have a role. It's just we need to get there.
What is the difference in X-ray exposure between the 2D and 3D mammograms?
Yes, that's a very, very good question. So again, with 2D mammogram, 4 static 2D images of the breast are taken. And in 3D mammography, again, the 15 low-dose projections of each breast are taken. And with the newest technology with 3D mammography, now it used to be that 3D mammography was twice the X-ray dose to the breast compared to a 2D mammogram. But now, again, with the newest technology, it's about 1.1 times that dose. So definitely the benefits of having 3D mammography far outweighs that 0.1 increase in the X-ray risk there. That's a great question.
Who's a candidate for the BRCA test? And is that a blood test, or what exactly is that?
So that's a great question. I should have added that slide in. There are some very clear NCCN guidelines for who gets genetic testing. In general, if a patient is under 45 years old with a diagnosis of breast cancer, we recommend genetic testing. And it's not only for the BRCA1 and 2 gene, but for a large panel of gene mutations that can lead to an increased risk of breast cancer. In patients who have a family history of a first-degree relative who was also diagnosed at an early age and then they are diagnosed. In patients who have a family member who does have a gene mutation that's known, we can always test for that. In patients who have a family history of ovarian cancer or a lot of prostate or pancreatic cancers, those can also be linked to many of the same gene mutations.
I have 2 questions. I lost my best friend when she was only 52 to breast cancer. That was probably about 10 years ago. Do you think there have been improvements in the last 10 years that we can show as progress?
Absolutely. I think we both have a lot to say about that. Absolutely. I think the biggest advancements are what we're seeing with screening and detection. In addition, the medications that the medical oncologists have through many clinical trials have gotten so much better. And that's why the overall survival is so improved at this point. And that's even within the past 5 years. So it's just moving forward very quickly.
Okay. Now, so my second question is, why does it seem like cancer seems to come back in people at the 5-year mark? Somehow it seems like that 5-year mark is an important marker.
So for many cancers in the body, once you've not had cancer for 5 years, you're considered cured. Breast cancer is a little bit different. We can see recurrences up to 20 or 30 years later in women who have had breast cancer. So unfortunately for the hormone receptor positive cancers, the ones that estrogen is feeding them, those cancers, although they're less aggressive, can show up again many, many, many years later. Interestingly, on the flip side, the more aggressive tumors, like you may have heard of triple-negative breast cancer and HER2-positive breast cancer, when we hit the 5-year mark in those patients, we consider them cured. And so there's something about the hormone receptor-positive cancers that can kind of sit indolent. Maybe they're hiding from our treatment a little bit and can show up later. There is not, in breast cancer overall, there's not a large bump at the 5 years for recurrence. But for those more aggressive tumors, it tends to be a little bit earlier, and for the hormone receptors, it tends to be a little bit later. But I don't have a good reason for this specific timing at 5 years.
I wanted to ask about, if you've had a mastectomy, what kind of imaging do you recommend, and what would, just for maintenance when there's no particular symptoms?
That's a really wonderful question. So obviously mammography can be performed on the contralateral breast, and that is something that we would still recommend yearly. and specifically looking at the mastectomy side. So in mastectomy patients, Dr. Kansal mentioned the recurrence rate is 1 to 3%, but where do these recurrences occur? So we can see this in the skin, in the chest wall, so the ribs, sternum region, and in the armpit area. And usually for mastectomy patients, breast MRI is the most effective way in terms of screening that mastectomy surgical side. Now, the native contralateral breast, again, still with a screening mammogram every year, but breast MRI could really help us in the setting of mastectomy patients.
Sorry, hi. Quick question on the effect of diet. Whether having milk or milk products has any impact on the diet, or soy products having, soy in general. Do you have any input on that?
Sure. The good news is milk does not seem to increase the risk of breast cancer. There was one study that came out that was in the news quite a bit, maybe last year, if not the year before, saying drinking milk is putting people at a much higher risk, but that hasn't borne out in further studies. Soy is a natural estrogen, so you hear me talking about estrogen a lot, but the amount of soy or tofu or edamame, the foods that have soy, you'd have to eat a lot, like pounds and pounds and pounds and pounds every day to really see a change in your estrogen levels. The other food, though, we do recommend people not eat a large amount of our foods high in nitrates, but that's like cured meats, such as pepperoni, salami. Once again, though, you'd have to eat like a really big charcuterie board every single day. And although that would be lovely, most people are not eating that much of it. So to be quite honest, it's more important to stay physically fit and to keep weight in a reasonable range to help offset any breast cancer risk. Less so specific dietary modification, even like with sugar.
Okay, I have two more over here, and then I know you have questions over there, so I'll be on that side next.
I have a sister-in-law who's had breast cancer, and she now just got a pacemaker. So each year post-breast cancer, she's had to have an MRI, but now she cannot. So what do you do?
Yes, so now most pacemakers that are placed are MRI compatible. And specifically, it was pacemakers that were placed probably about 10 or so years ago that were deemed kind of MRI incompatible. But even these pacemakers usually are compatible at a lower level magnet, so a 1.5 Tesla magnet, which we do have one of. But most MRIs these days that are placed this day and age are MRI compatible and can be imaged on our strongest magnet, which is our 3 Tesla magnet. So that's a great question. But even with the older pacemakers, the 1.5 Tesla that they can get imaged on.
Your thoughts on the many estrogenic chemicals that we are ingesting and are all around us in our environment?
Well, we are seeing a gradual, and which is sort of picking up steam, increase breast cancer prevalence, and possibly that's part of it. I think that our environmental exposures are, and the food we're eating and all of these things clearly play a role. And that could be part of what we call epigenetics, which is really changing things within our bodies. That's what's exciting with our colleagues at the Susan Samueli Institute. They're really looking at a lot of that with the environmental exposure and diet and many other things. And so hopefully we'll get some more answers.
My questions are for both of the doctors. In your experience, have you seen patients when they get like either a 3D mammogram or ultrasound, they have say like something that looks like a tumor or a cyst, and are they dangerous? Like for example, are cysts dangerous? Do they turn into tumors or something? Or they find a tumor and it's not cancerous? Does that require surgery? Like what will be the options for the patient? If I could just get your thoughts, thank you.
Yes, that's a great question. So on imaging, we find not only breast cancers, but we see a lot of benign findings as well. So your question specifically was about cysts. So cysts are benign collections of fluid that we see very, very commonly within women's breasts. And cysts, if they are purely cysts that we can see on the imaging, and imaging shows us very clearly if something is filled with fluid versus something that is solid. A pure cyst does not have any risk for developing into cancer. There are also benign solid lesions, which, for example, what's called a fibroadenoma. So fibroadenomas are the most common benign solid breast mass that we see in women. And those pure fibroadenomas, biopsy-proven fibroadenomas, they have no malignant potential whatsoever. So breast imaging does show us the ability to find breast cancers, but we see a lot of benign findings as well.
Okay, we have 2 more questions over here, and then
I just had one additional dietary question of a very close friend of mine who has breast cancer or had it, became vegetarian, more towards vegan. Does not eating meat or eating a mostly vegetarian diet have any ability to help prevent other cancers in the body, breast cancer included?
With breast cancer specifically, we haven't seen that correlation, eating a vegan or a vegetarian diet decreasing the risk significantly. I do think that we're learning more and more about plant-based diets and how important that is. There are many dietary changes for, say, colon cancer that can be helpful in that risk reduction. So I don't have a specific answer to that.
and this will be our last question.
Thank you. I'm sorry I came a little bit late, but I had a question about like recurrence. If you get metastatic breast cancer, well, you talked about the risk factors for regular breast cancer, like the first time, but is it the same for like the recurrence? Am I kind of making sense? Yeah, I'm just asking.
Sure.
Yeah.
So interestingly, it is a little bit different in that since somebody has already had a breast cancer, they're going to be at a slightly higher risk, of course, of getting metastatic disease compared to someone who never had the breast cancer to begin with. One really important lifestyle modification is exercise. A lot of new data is coming out showing patients who do aerobic exercise 3 to 5 days a week can drop their breast cancer risk of recurrence by almost 50%. So that's almost better than any medications that we have or other things we can do to intervene. But a lot of the same things ring true for recurrence as well. You know, just trying to stay healthy, limiting alcohol intake, no smoking, all of those things.
Okay. Oh, all right, one more.
Just one more. Is there some indication why exercise might decrease the breast cancer, or is it just correlation?
I think it's very multifactorial, and it's hard to say what came first, the chicken or the egg, of course, because if we're exercising a lot, then likely we're less overweight, and maybe we're drinking less alcohol, and kind of all of these pieces fall together. But they did on these studies take patients and have the placebo group who was not doing kind of a dedicated exercise regimen, and then have the groups that were doing a very strict exercise regimen, and that's where they were seeing the difference between matched groups. I don't know exactly the reason why, but I think it's generally overall how important exercise is and helping with. I was going to say, me too. Yeah.
So we all have to stay fit. It sounds like this is going to be a real breakthrough nationally, isn't it, this new medical center?
I think so.
You want to tell us a little more about it?
It's on the corner of Jamboree where the UCI wetlands used to be. I'm not sure if you've seen the building already go up. But we're very excited. Our breast cancer center is going to be opening, like Dr. Kansal mentioned, in early 2024, January, February, and it will be really a multidisciplinary approach, like Dr. Kansal mentioned, where breast radiologists, oncologists, radiation oncologists, surgeons, we're all going to be in the same workspace, seeing patients all in conjunction. So we're very, very excited about that.
Thank you. We're very fortunate to live here and have this beautiful university and all of these wonderful people. I thank you so much, Dr. Kansal and Dr. Tsai, for being with us. And thanks to all of you for being here. Our next meeting will be November 14th. Dr. Hamid Jalilio, not sure if I'm pronouncing it correctly, but he will be speaking to us about hearing loss and the most recent innovations. You may have been seeing the advertising now. You can buy your hearing aids at CVS or Walgreens. So, all right, so we hope to see you. If you didn't get a bookmark, we have bookmarks in the back. If you aren't a member, we'd love to have you become a member, and we hope to see you here again in November. Thank you for coming.